So I'm going to just kick it off with the first question. We didn't talk at all about MRD. It is a key topic. So what's the influence of MRD? If somebody wants to talk about the ODAC, they can, and explain what that is. MRD is a clinical trial endpoint. I'm just going to open up the MRD topic for discussion with the panel. So who would like to kick that off? Jeff? Oh, well. Okay, Craig, you can.
So the Tigers got a hit. They went to third base, and then the guy struck out. But our pitcher's doing awesome, so I think we're safe. To back up a little bit about what MRD is, and so, the test that we use to determine how much myeloma you have, the SPEP, the free light chain test, and the 24-hour urine, those tests, the 24-hour urine is what, 100, almost 200 years old. The SPEP is from the 50s, I think, and the free light chains are about 20 years old, so they're very old tests to determine how much myeloma. And thank goodness we now have, and they only go down to a certain extent. And so even when you are immunofixation negative, the question is, do you have any disease that's left over? Is there anything left? Because the fidelity of these tests are limited. And so one way to be able to tell is to do MRD. So and one way you can use MRD is to say minimum residual disease. So disease that is below the level of detection of what the lab tests can do. And it's really kind of smart, because what it can do is that you get a finger, every Buns myeloma has a unique molecular fingerprint, and you can get the original bone marrow biopsy, look at that fingerprint, and then match that to a fingerprint in a new bone marrow biopsy, which has the fidelity of being able to find one myeloma cell in 1 million normal cells, which is and if you have an MRD negative, that means that your response is so deep that they can't find any myeloma cells in 1 million normal cells, and they usually combine that with a PET scan to be sure there's nothing else hiding. So that's the next generation sequencing MRD test. There's another MRD test with using flow cytometry, which has a little bit less fidelity, but still very, very easy to do on a bone marrow sample that can find one myeloma cell in like 100,000 or about 100,000 normal cells. And the good thing is that when people are MRD negative, the deeper the response, the longer it takes for the disease to grow back. And so it's a good correlate to be able to tell how long someone's going to stay in remission if they're MRD negative. And so one thing that the myeloma doctors did is we went to the FDA and said, we have these great responses of all the drugs that we've talked about all day long, but we have to wait a really long time, thank goodness, good problem to have, before people start to relapse with some of these new therapies. You have to sometimes wait 5 years in order to see how long a particular therapy lasts. So how about, instead of using progression-free survival, how long does it take for a disease to relapse after a certain therapy, why don't we use MRD as a surrogate to that, and which will have us being able to determine the efficacy of a drug without having to wait years and years and years and years in order to get those results. And so the FDA, the advisory board agreed to it, and so we're waiting on the final approval to that. But that will be revolutionary, to use Matt's word, because then it will allow us to get, the cadence of being able to get drugs approved by the FDA will be at a much higher rate because we don't have to wait as long for it. And but also, and I'll stop after this, let someone else, because I don't want to hog the microphone, because I got to check the score.
I'll let you know.
You'll let me know, but I'm still going to hand it off. Is that we can also, the big question that we have is, can we use MRD to response adapt therapy? And what that means is that if someone is MRD negative, can we stop their maintenance therapy? If we've done all this work, with the transplant, the induction therapy, and the MRD negative, can we use that to guide therapy? Because, I think one of the most frustrating things that I have is that when I talk to one of our fellows about how do you treat myeloma, they go, "They're RVD." And what do you do after transplant? They give very rote responses of how to treat myeloma, not based on what the response of that patient has had. Because one question is, if you're MRD negative, maybe we can adapt the therapy to a response instead of just following, what a paper said to do.
So I think another, those are great points. One, sort of other really interesting piece of development with MRD is trying to look at ways that we can add, a kind of new technology to what's currently in use. So, no one here likes bone marrow biopsies, right? So I guess, one of the things that we're trying, that's been an area of research that isn't currently active, is to say, can we use blood tests and apply some of these MRD technologies on the peripheral blood and see if that can serve as a useful marker. Currently, that's not sort of readily available, although Mayo Clinic has been developing, and Dr. Gertz can probably attest to this, some of the mass spectrometry tools, which is a very sensitive instrument that can detect tiny amounts of protein and tell us the size of those proteins. And we can sometimes detect myeloma proteins that would otherwise not be wouldn't be detectable with the protein electrophoresis tools that we have now. I think it's an area that is promising, but I think we have additional information that needs to be found about how reliable this test is. Does it always match what's going on in the bone marrow? But certainly I think as we're learning how to implement MRD into our clinical trial designs to get earlier approvals of drugs, wouldn't it be great, hopefully sometime in the future, for us to be able to do MRD on blood work and skip out on bone marrow biopsies?
So people with myeloma have an abnormal protein in the blood. That protein was detected by a test called electrophoresis. Electrophoresis separates your blood proteins based on their electrical charge. The technology for separating proteins by their electrical charge is just about to turn 100. That was Arne Tiselius. He won the Nobel Prize in Chemistry working in Uppsala, Sweden. But separating proteins, charge is a great way to do it, but you can also do it based on what they weigh. Different proteins weigh different amounts, and in fact, the abnormal proteins in the blood that you have a very unique weight specific to your myeloma. It's possible to separate those proteins. Those proteins, when you separate by weight, it's 30 times more sensitive to detect an abnormality than separating by charge. The standard to say my myeloma is at the lowest possible point is a bone marrow. But I don't have a lot of patients in my practice who are coming into the office saying, "So when's my next bone marrow?" In addition, bone marrow and myeloma is kind of focal. So if you did it on the right and on the left at the same time, you don't always get the right answer. And there's also, if you draw out, let's say, 2 teaspoons of bone marrow, the first teaspoon may have more myeloma than the second teaspoon. It's not all homogeneous. So which sample gets sent to the lab can be a problem as well. So MRD by bone marrow analysis is not perfect. But if you get it out of the blood, you kind of think it's kind of a homogeneous sample. So we've been looking at patients who are MRD negative by standard bone marrow criteria. Beautiful. Half of those patients still have a detectable myeloma protein when you look using the sensitive technique of finding it by weight. And when we look at the patients who are MRD negative in the bone marrow, but positive by having an abnormal protein persisting, they don't do as well as the patients who are negative in the bone marrow and negative in the blood. Well, then the next question is going to be, well, then can I just do the blood instead of the bone marrow? We're not there yet, but actually, I'm kind of a true believer that we're going to be doing the blood test on a monthly basis, which is what we're currently doing. The other thing is that if you have IgG kappa multiple myeloma, some centers can't tell if the protein that's left over is the myeloma protein or Darzalex, because they're both G-kappa monoclonal proteins. Those people taking the bispecific antibody teclistamab, trade name is Tecvali, I think, that's a G-lambda monoclonal protein. So if you have G-lambda myeloma, some centers can't figure out, am I looking at drug in your bloodstream or am I looking at your myeloma protein? Mass spec can fix that because they don't have the same weight, even when they have the same charge. And so we used up a third of our time on MRD. I will have to say, though, that although it's a wonderful prognostic feature, and I'm so glad that the FDA is giving us new agents, I'm not using it in my daily practice to make decisions. It's great if you get it, but if you don't get it, I'm not changing your treatment. And if you need to stop Revlimid, the most common reason I stop Revlimid in my practice is the patient's driving it. They can't handle the diarrhea anymore, no matter what, it's making them nuts. Or the fatigue they have from the Revlimid is so difficult that they want to get off it. That, for me, is the biggest driver, is patient-driven based on toxicity. So, yep, and it may be that MRD negative patients will be able to stop, but that still remains to be determined.
Okay, great. Okay, we're going to open it up for questions. We've got 2 microphones on each side. Go ahead.
With the IBEX trial, lenalidomide to iburamide, do you have to have an SCT before you can be put on that trial? Or can you,
You have to have a
transplant?
Yes.
You do?
So the IBEX trial is the combination of iberdomide
Right.
plus daratumumab for patients who've undergone transplant as part of their first line of therapy. And the treatment that they had to have had before the transplant, there's two other details. They have to have already had DARA as part of their induction therapy. There's a very specific reason for that, because what you get out of adding DARA might be different in a group of patients who've never had DARA as part of their therapy versus patients who have when you're using it as maintenance, right? So we just wanted to try and make that uniform and take that variable out of the equation. The other thing is they have to have some kind, on this particular study, because we're looking at conversion to MRD negativity, patients still have to have some measurable disease by some test. Some of the patients that have been enrolled actually have a detectable M protein or elevation of light chains still, like they're not in a complete remission. We have some patients who are in a complete remission except their MRD test is still positive, and you could potentially be eligible in that case, but we're looking for that MRD conversion as the primary endpoint of the trial.
I had DARA, Revlimid, and dexamethasone in a clinical trial, but I have not had a stem cell transplant. I don't know if that's in my future or not, but I would just be out of luck with this then.
This would not be, right. This trial is not designed for that situation. Again, obviously, there are different reasons why somebody doesn't necessarily pursue transplant. We learned from Dr. Cole that transplant does, on average, extend the progression-free survival a bit compared to not getting transplant, but you have to carefully select your patients, right? And so transplanting patients who aren't really healthy or strong enough to get through transplant will just be associated with extra side effects, right? And so there are patients who opt not to get transplant because they're a bit more frail. And we talk about progression-free survival being different, but the one thing transplant doesn't, kind of consistently over time hasn't shown is an improvement in overall survival. Progression-free survival that's shorter means, on average, you're likely to have to start second-line therapy a little bit earlier than somebody with longer progression-free survival, but it doesn't mean that more patients are dying. It means they're moving through therapy a little bit faster, generally. Okay, and so because they're, that same determination study that was discussed this morning, and several other studies have not shown a survival benefit from transplant, a lot of patients who are sort of have ambivalence, end up leaning away from transplant as part of their therapy, and that's a very individual decision. And as long as you understand the pros and cons of doing it or not, I mean, any rational physician should be able to accept that decision on a patient's part, I think. It's an informed decision.
We have a question over here.
I'm currently waiting my MRD test results, but I'm doing the clonoSEQ test, and so they compared it to my original bone marrow biopsy in 2011, but there were issues with that. So then they are using the bone marrow biopsy from 2017 when I relapsed. But why do they need to compare it to my past results? Isn't it just a point in time measurement? Isn't it just how my myeloma is, how many cells are in my body today as opposed to how many I had at diagnosis?
So actually, the reason they need that original sample is to determine the exact clonality of your myeloma. Clonality meaning the type of abnormal myeloma cells that your particular cancer is producing. And usually, it's thought to be a static process, but they do change over time, and what remains is kind of the resistant clones that basically have managed to survive all the therapy, but they do want to match it to that original clone that you had of abnormal cells when you were diagnosed initially, and that's why they want that initial bone marrow sample.
Mention flow then as an alternative. Okay. So again, it talked about the two ways in which MRD is done. One requires DNA primers, an amplification of the DNA. That requires a sample that had myeloma. But it's not the only way to measure MRD. It's also done by a technique called flow cytometry, where you're detecting myeloma proteins on the cell surface. That doesn't require a prior bone marrow sample. So if clonoSEQ doesn't work, which I think 20% it misses, flow is a very good alternative. And so it's not the only way to measure MRD.
Most centers do the DNA-based test because it's readily commercially available. But you have to, that first sample, think of it as like getting the fingerprints so that later you can look for those fingerprints, right? That's really what you're doing. It's your comparator that allows you to identify if there are small residual cells that match those original ones.
I will say that we're using flow at Mayo exclusively because it's a referral practice and people are coming from all over the place and they had their bone marrow over here and yes, is there sample left over in this? And it's not, because you have to actually plan for that in advance. And so we're doing exclusively flow because we don't consistently have access to most samples.
In most clinical trials, this is still. Oh no, they did. I didn't get a lapel one. So, but most clinical trials, when they report out results, will have both. They'll have both flow and NGS included in it. So when the decision process is done for some of these drugs, that both are available.
The fact that you don't have a lapel and we all do is a disparity.
It is truly. Oh, but I have to be on point to, check the score.
Thank you.
This is do or die.
Can I make one other comment about MRD results if you're doing it through the assay that you mentioned, the clonoSEQ? We've been talking about it as a yes, no, positive, negative. Really, it's a depth of suppression, and so the assay can actually measure down to 1 out of 6 million cells in the marrow, 10 to the minus 7th. So you can really measure very, very deeply But the definition of MRD negativity for a study might be saying like, patients have to achieve at least 5 logs of suppression instead of 7 logs of suppression. So you get these like sort of confusing results. You get this result where, I tell you, you reached the MRD negative threshold for this study, the IBEX study. And then the report that you're staring at and that I'm also staring at says, and you still have 12 detectable cells per million. Because that's 10 to the minus 6th suppression, and the threshold for this particular study uses 10 to the minus 5th. So we need to get out of the mindset of thinking of MRD as a positive or negative, but achieving a certain depth of response. And the deeper, the better. And the deeper you go, the more prognostic significance it has, because as Craig said, the deeper you are, the longer it takes for the myeloma in general to recover from that deep, deep suppression. And so it means more to be deeper prognostically, but anybody, I think we'd all agree on this point, anybody whose disease can only be measured by an MRD test has had a good response to therapy. And that's why outside of a clinical study, we are right now generally not making treatment decisions based on an MRD result because we have definitely not established that you can stop therapy in all patients who are MRD negative. We think there might be subsets. We don't know that yet. And we also, and I just lost my train of thought, so I'm tired. But
So with induction therapy, you don't achieve MRD therapy, transplants pending, they're still MRD positive, you changing treatment?
I'm not.
I'm not.
Yeah, that's what I was going to say, is that we also don't know that it's beneficial for patients to rifle through lots and lots of therapies, chasing this holy grail of completely undetectable by MRD negativity, and before you know it, a patient who's never actually progressed has had 3 lines of therapy. That doesn't make sense. You want to save those arrows for later.
For years, I've been telling Xander what he's thinking.
Okay, what other questions?
I want to thank the panel for coming today. This has been fantastic, being in the presence of such knowledge. Thank you very much. My question goes back more to an ancillary therapy for the bone builder up medications, Xgeva and Zometa. And please speak to when we can get off of these. I've been off of this stuff on this stuff for like 8 years, and I'm tired of it.
I can try to address that. So, so bone disease and myeloma is an important problem. So we have, when the disease is active, it harms the bones, and we all give active myeloma therapy, hopefully get patients into a place where they're in remission or their disease is under control, but still the bones don't necessarily heal up back to what they used to be. So we found that patients still remain at risk of fractures and other complications to the bone structure. So we try to give some help to the bones using some medicines, zoledronic acid or Zometa being probably the most common one, which is generally an IV infusion. And along with some calcium and vitamin D support is generally standard practice for myeloma patients who don't have an immediate reason like a dental problem that would preclude doing that. Xgeva, also known as denosumab, is a monoclonal antibody drug that also blocks the development of the normal cells in your bones whose job it is to break down bone. So just to step back a little bit, the whole process of our bones is often under continuous maintenance where cells that build bone and cells that break down bone work in a healthy balance, and normally that's how our bones are maintained. In myeloma, that process is shifted completely towards bone breakdown. The cells that break down bone, called osteoclasts, are working overtime and around the clock to break down the bones. So these drugs basically either kill osteoclasts or block their development. Zometa kills them. Zoledronic acid kills them. Xgeva or denosumab blocks their development. So essentially, to keep the bones happy, we're sending the cells that break down the bones on vacation, hopefully for quite a while. But the duration of therapy at this point in time is kind of unclear as to what's the best method. I mean, general guidelines suggest 2 years of treatment with Zometa or zoledronic acid as part of initial therapy. And then, oftentimes I think people can then stop. The issue is at time of relapse, it's kind of up to the discretion of the treating docs as to like if a patient has a lot of active bone disease, whether to resume or not. One caution is that we know that the effects of Zometa are long-lasting, and after you get off Zometa, it works its way into bone structures and I think provides some reduction of risk in fractures for time, well after people are off the drug. But Xgeva does not. So I think the challenge with being on Xgeva or denosumab, beyond the fact that it's way more costly, is that the protective effects of Xgeva require the drug to be continuously given. So I feel like Dr. Gertz has something to say, and I want to let him get it out.
There's more history here. There's more history here that's very important. So when the original bisphosphonate study on pamidronate, Iridia, was done, that was 23, 25 years ago, the majority of patients were on melphalan and prednisone. And this issue of skeletal events in myeloma, rib fractures, bone fractures, broken hips, in that era, it was crazy common to see all that because our treatment sucked. We were happy if half of our patients had a 50% reduction in the M protein. And so it was demonstrated with pamidronate that it was clearly superior in preventing skeletal events. The successor drug, the zoledronic acid, the Zometa, was powered to show that it was equivalent to Iridia. Not reducing skeletal events, but it was as good as Iridia. Fulfilled it. But over the 25 years, our ability to treat myeloma has changed a hell of a lot. And now we have, Dr. Zonder said 90% remission, 60% MRD negative. So then myeloma cells aren't there making the chemicals that leach mineral out of your bone and make your bone softer. And all of us in current practice, after therapy begins, they can tell you how often they see a skeletal event in a patient in remission on treatment. Doesn't happen very often, but the jaw thing's 6%. Now let's talk about just women with osteoporosis out in the community. Their doctors say, you're on it 5 years, you better get off it. For how long? I don't know, a year or two. Why? So to allow that bone remodeling so you don't get those goofy fractures. So we're telling those people, there's millions of women, 5 years, you're done, yet the duration is unclear. Well, we actually approached the company that made the Zometa and said, we'd like to run a trial to tell you when we can stop it. And they said, yeah, we're not paying for that. And so it's not clear. And this 2-year comes from 5 people like us sitting in a room saying, what sounds good to you? What sounds good? Okay, every 3 months for 2 years. Nobody knows. If you're in a deep remission, if you have active myeloma relapse, you're making the chemicals to wreck your bones. That's not a good thing. But if you're in a deep remission, the likelihood of an event is small. And if you said, I'm stopping my drug, I'd sleep fine.
Is there a weaning process?
One additional point is to say stopping denosumab. In theory, because the drug doesn't kill the osteoclasts, it just blocks their development. When you release the block of development, you got all these teenager osteoclasts who are ready to get out on the road. You want to stop them. And so in theory, it might be a good idea to get a dose of Zometa after you stop the denosumab to sort of, keep the teenagers home and revoke their driver's license. Sorry for the analogy. Yeah. I think you don't need to wean, but I think if you've been on Xgeva, you should probably get Zometa as the last final act of that chapter.
So is there a weaning process for the Zometa?
No.
No.
As it stays, because it stays in your body for like 10 years.
It does, and I think that if you find yourself in a dentist chair needing a tooth extraction or an implant, it's best to bring it up. You might want to have some preventive antibiotics. We're all humans. We're probably going to have some dental issues down the road, but there's not a weaning process. But I think you definitely want to make sure that your dental providers and your hematologists can chat about any work that you need done.
But one kind of thing I was kind of surprised at is that when they looked at who gets, I mean, the guidelines say that every newly diagnosed patient, should get Zometa. In reality, it's almost 50%, which I thought was quite shocking. That out in the community, lots and lots and lots and lots of patients that have myeloma don't get Zometa, and I'm not quite sure why. It's primarily, again, blacks and Hispanics who don't get it, but I thought it was also surprising that about only 75, maybe less % of patients actually get maintenance therapy. That a lot of docs out in the community sometimes aren't even aware of maintenance therapy, and so that's why I think it's always good to, as Jenny had mentioned earlier, about having some type of connection with a myeloma specialist to get a second opinion to make sure that everything is going smoothly.
If you have kidney issues, you can't take Zometa, can you?
Yes.
You can, but it depends.
Depends.
I think,
I'm taking Prolia
Well, then you can take-
because I
you can
could
take
not take
Pamidronate.
Zometa.
yep.
It depends. You can adjust the dose of Zometa for the degree of kidney function. If the kidney dysfunction is too severe, we tend to avoid it. But Pamidronate, which is a closely related drug, and again, equivalent in a head-to-head study, can be substituted and used at a slightly modified dose. We use, somebody with real, we might use 60 milligrams instead of 90 milligrams, but it's, they're usable, and so is denosumab.
Because my kidneys failed and I'm on dialysis, so that's why I do Prolia.
Yeah, but also making sure, calcium and vitamin D. So it, yeah.
Those
to
get
have-
checked twice a month.
Yeah, to have that combo.
So, Dr. Cole, my question is it the bone density for why more African Americans don't need Zometa?
No, so everybody, so the increase, so does bone fractures
Okay.
are less common in black patients. The bone disease is, I think, the same. And so everyone should get. So the reason that black people and Hispanics and Latinos aren't getting Zometa is one of the disparities, bone strengtheners is one of the disparities that exists in treating myeloma. There is no reason for that. There is no logic or science behind that. It is just access to care.
So everyone should get
Everybody.
Can I just say something?
Yeah.
Because we were talking about supportive care, and it's kind of a big deal, and we're running out of time. It hasn't come up, but people all the time are saying, so what can I do about my myeloma? I'd say there's two aspects of it. One, hasn't been discussed, vaccination. I mean, I'm so sick of seeing shingles, and I'm astonished at how many people haven't had the shingles vaccine. I'd follow shingles, followed probably by COVID second, pneumonia third, and RSV fourth. And so those vaccinations are such a big deal, particularly as we start moving into bispecific therapy and the infections they're going to produce. And the second thing, I think, it's really important, you've heard it from everyone, is that know your protein. I mean, know whether you're G or A or Kappa or Lambda, so you know what your provider's following and monitoring to say you're better, you're worse, things are stable, you're in a plateau. Know your protein. And also it's helpful, particularly if you get a second opinion, actually learn your medications, Please don't tell me you're taking the round blue one and the oval yellow one. It's really not productive, The most common answer in my practice is, well, you flew in 700 miles to come see me, and I say, what are your messages? Oh, I left them in the hotel room. Please don't do that.
Okay, we have time for probably, were you going to say something, Dr. Cole?
But I to echo again, and I know in my session we had talked about this, there really is no other cancer where you can, in real time, know exactly where your disease is. And, again, if you have, colon cancer, you may need a colonoscopy or a CT scan to know where your cancer is. With this, you can ask your doctor, where am I? And that is a huge point of empowerment, because that puts you in control to know exactly where your disease is. So, I sit there and I worry about all sorts of things. But with myeloma, you don't have to worry because you know where it's at, and you can discuss that with the doctor. And so because we did a study, we found a lot of patients don't know where their disease is at any particular time. And so again, the preach is to be empowered to know where your disease is and discuss this with your doctor. Don't let your doctor walk out without saying anything. Slow down your doctor. We are pushed to see patients. Slow us down if you have any questions. Be empowered to say, wait a minute, before you go, what was my M protein last month? What's my level of response? CR, VGPR, PR, where am I? Because that puts the power in your hands.
And this is why you should have a HealthTree Curab account, because you can
Absolutely.
just have it in there with your lines of therapy, right? Okay. Oh,
If you are taking a Cyclovir and the single shot, is it right to do both at the same time? A Cyclovir and the single shot?
I think the question was, should I be taking a cyclovir and the shingle
And the
shot
shingles, yeah.
at the same time? Is that right? I think it's a hard question. I certainly know, I know a cyclovir works quite well to prevent shingles, and I think that our myeloma patients' immune systems come to the table with different fitness. So in general, I think the shingles vaccine probably works, but personally, I am uncomfortable telling my patients that they don't need a cyclovir, even if they've had the shingles vaccine. So I tend to ask my patients to do both, because shingles is really a terrible problem to have, and I do both. I don't think it's harmful, and I don't think the shingles vaccine replaces the need for a cyclovir.
I think the sense I get is that's our general practice, but if I have a patient in that situation who's really insistent on wanting to come off the acyclovir, I measure antibodies to see if they've responded to the vaccine. Like if you can't detect antibodies to varicella from the vaccine, you can question how protective it actually is going to be off acyclovir. So most of the time after we talk through it, we just talk about the fact that these things are probably additive in their protection, at worst, and there's no overlapping toxicity. So the downside of being on them is just, honestly, it's the downside of just having one more medication in your medication tray. But you shouldn't have excessive toxicity from getting both, and that's what I think most of us do.
That's how scared we are of having a patient get shingles, is that we're doing two treatments.
Yeah, we did when I was in Wisconsin, we did a study of the shingles vaccine when it came, the one that's safe for myeloma patients, the inactivated one, versus having both. And the people who just had the shingles vaccine, they had a few more breakthrough shingles episodes than the people who are on both. And so I tell patients that if they want to just go with the vaccination, that they might get it, their protection will be better with both.
okay, one more. Oh, we have several questions, but let's take just two more questions.
First of all, you all seem like very caring, concerned doctors, and that's not the case in this world today, so I applaud you. My question is, my question is to all of you, and this just doesn't happen today when you go to a typical oncologist. Do you at all talk about stress? Because we all know that stress kills. And especially people that are dealing with smoldering myeloma, that's even more stressful, I think, than anything, because you're waiting, you're watching, you have no idea. So do you help patients deal with stress when they come to see you in your office?
Yes. And the way I think one big point of the stress, especially, I give you totally the, what is it called, active surveillance, I think, where you're watching the disease. One, one thing that when we have patients come into the office is that they meet with the social worker and we do an assessment of their level of stress when they walk in the door. So when you go into your doctor's office and you see the little thermometer, don't do a lot of folks do, is that they say, I'm gonna put 0, but I'm really stressed out. Because then we can't help you. Then we don't know. And we did a study a while back that when myeloma patients go to their physicians, over 30% of the time will the patient discuss with their doctor that they have any type of distress. Only 70%, or more than 70% of the time, the doctor did not ask about stress. Did not ask as part of their, you're having diarrhea, you're having neuropathy, they didn't ask about stress. So patients are not saying it, doctors aren't asking it, so then you have to be empowered to say, this is where, because I can definitely help with it, and I definitely have resources to help with that, but I need to remind myself to ask about that, and the patients need to feel comfortable reporting that. And when we ask, well, why aren't you reporting that to us? The response that they gave was, well, the doctor can't do anything about it. And that's not true. That we have, thank goodness, we have resources upon resources to address that, but we just have to know if you haven't. So I think that, and again, be empowered to say something. Because it is not uncomfortable to talk about depression, anxiety, stress, distress, but be empowered to do that so that we can help.
Okay, last question.
Thank you. First of all, Dr. Cole is my hematologist from U of M, and I just followed him on over to Lansing, and 10 years ago. So I've had 2 years I was diagnosed actually this month 2 years ago with multiple myeloma, and I was MGUS and smoldering for years, so I never thought I'd be at this point, but I am. And I just feel that this journey is not about us all the time, it's also about others and to help them along the way with their journey. But I have 2 things actually. First of all, I know research comes out all the time, and this is for anyone, but number one, first question is relapse. And that's always in the back of our minds. I did have my stem cell transplant here with the team at Carbona's, Dr. Ash and others. Excellent, highly recommend it. And my question is, with the relapse, what is research saying right now about how far, if you're on the maintenance meds that I am, Dr. Cole makes me do it whether I want to or not, and I'm on maintenance right now. My question is, for all of us, is what is research saying now? Is that pushing us farther out? Is it the same no matter what our nationality is? And the second thing is, I am on Zometa. Dr. Cole makes me take it, along with the Dara shot. And yeah, he forces me. And I go to him on the 22nd, so I'm praying that he pushes it out of 6 months or something. But at any rate, my question for that is, I was told by my stem cell transplant team that they did not want me to take the shingles shot right now because, as Dr. Cole said, there's one that may be positive for my body, may not be. And is that what you all recommend, or should I take the shingles shot? I'm on the Zometa because I'm also taking acyclovir twice a day. While I'm on the Zometa, she wants me to stay on it. So that's 2 different questions I want answered.
No,
Thank you.
first, Dr. Cole is not making anybody do anything. I wish that people on this earth would do what Dr. Cole said to do. Because then the dishes would be totally, the twins would wash the dishes, and they would wash my car if I could get people to do what I asked to do. But nobody does that. So, come on. I think that one thing, I think that we've talked a lot about just, to again coin what Matt said. I mean, a revolution in what relapse therapy. And if you want to see, the pointy end of research in myeloma right now is directed at relapse therapy. I mean, everything, all of our clinical trials basically start there and then move towards upfront therapy. And so when you look at the science, I mean, we spent 5 days, in Rio, locked in a room for the most part, talking about relapse therapy and relapse therapy and relapse therapy, the science behind it, and what we're going to do about it. Because really, I mean, no joke, our goal is to cure myeloma. It's not to just have it just sit and exist, which we've done in the years previous, but it's to cure it. And of course, what I say is that you haven't cured it for anyone until you cured it for everyone. That's what we're trying to do, and that's where the research sits. I think that was your first question.
So what's the percentage of us getting it or relapsing? What is research saying?
Almost 100% of patients relapse at some point over the course of their illness. I think some patients, sometimes we bat around this term like functional cure. Like, you have an 87-year-old patient who goes through induction therapy, has a great response, is on low-dose Revlimid maintenance, and lives out their life on Revlimid maintenance. Or I had a patient who, was on, bispecific therapy and was in the best response she ever had, and she was 90 years old, and she died of other causes, and, she wasn't. I'm reluctant to use the word cure. True cure, because if you have to be on maintenance therapy to maintain that response, it's not the same as getting therapy, myeloma's gone, and it's in your rearview mirror. It's not the same thing. So, I mean, it's possible, there are circumstances, but I mean, if you're your age or my age, and you have multiple myeloma, chances are at some point you're going to have to deal with a second-line treatment decision. I mean, just statistically, that's highly likely. I mean, it would be quite an exception for it to never come back. But there are exceptions. I've had patients who've gotten over 10 years from their first line of therapy. Certainly, I think all of us have.
Yeah. And I think that's our big challenge. That is one thing that we've tried to do but haven't quite figured out. Is that it really is. I think it was Sajid Kumar or Vincent that had said how it's multiple myelomas, that people are very, very different with this disease. And and again, my frustration is that when I ask one of our fellows, how do you treat myeloma? They say Dara RVD. But there are so many different flavors of this disease. I have given 3 drug therapy to someone, and they've been in a remission as long as I've been in the state of Michigan, so which is about 10, 11 years. And I've had other patients that I've treated where I've given them everything that I have, and they died in 3 months. And they both have multiple myeloma, and when you look at their cells under the microscope, they're identical. So our challenge is really to figure out the different multiple myelomas. And there's studies that have been looking at that and trying to figure that out. But when I've talked to a cytogeneticist, actually a molecular biologist trying to look at this, he says the most difficult disease he's ever worked at and trying to figure out the different subtypes of it has been myeloma, but that is an active area of research to see who is who in the zoo. And I hope in the future we'll be able to say, you have myeloma X, you have myeloma Y, you have myeloma Z. We'll treat those people with different therapies, with different intensities, and be able to give a better answer to your question.
Oh, and the last thing you asked, I'm sorry, just speaking to you specifically asked a question about ethnicity and maintenance therapy.
So should I get the shingles and then I'm on Zometa, acyclovir, I'm getting the Dara shot and daily meds?
I mean, that the supportive care recommendations don't vary according to ethnicity. I mean, it's usually other clinical factors that would determine whether or not somebody would be a candidate. The main demographic detail that determines like whether you should get a certain vaccination or not is age. You know, are you over 60? You qualify for certain vaccines if you're over 60. If you're under 60, you don't. You know, like that. But you know what I'm saying? This is what I like. So it's not race or ethnicity that determines what standard supportive care should look like, or duration of maintenance. You mentioned that in passing too. On that abstract that we heard about earlier, the determination study, when we were looking at ethnicity, black patients were a little bit less likely to start maintenance therapy than white patients on the study. But the patients who did start maintenance, if anything, they were on maintenance actually a little bit longer, not shorter. So once you're on maintenance therapy, it was tolerated equally well, and the percentage of patients with dosage reductions wasn't particularly different.
Okay, and Dr. Cole, are you going to give us a score up?
Yep, top of the fifth, 0-0.
I have sort of one final point to say is that, adding on to what Craig had said, we try to do our best to treat as many of our patients. Since it's so hard to know like what different types of myeloma people have, we try to use trials and the results from those trials to best inform what we do. We know Revlimid applied as a maintenance therapy indefinitely until time of progression. If you look at results of all the trials, it seems to make people's lives longer. So we do that for pretty much, for most patients. Like the paradigm has been continuous therapy. We think that giving more treatment longer, controlling the disease has been the paradigm that has helped people do the best as like a population. Where the sharp pointy edge of the spear is going though, is that as we learn more about individual subtypes of myeloma, or we can use very sensitive tests like MRD to know how people are responding, maybe we can start fiddling with that approach for certain people, is to give them very effective therapy for a little while, look really hard for the disease, find that we don't see it anymore, or that it's hiding, or maybe there's one in a 10 million or 100 million cells, and then maybe try to individualize care more, given that the disease is so different among people. So, we use maintenance as a kind of a blunt instrument right now, I think, but, what we have to think about and be thoughtful of, and that's what role myself and my colleagues up here can do, is to try to think thoughtfully about each person's case and try to tailor his therapy and the approach as best we can to your individual situation. And it doesn't mean you have to necessarily get your direct care from a myeloma expert, but it's a good idea to have someone on the squad, on the bench or in the bullpen or whatever. Dugout, maybe? Yes. Right. Thank you for your question.
Okay, I just want to, let's give them a round of applause. Dr. Gertz had to catch a flight, but Dr. Parikh and Dr. Pianco, Dr. Cole, and Dr. Zonder, thank you so much for being here. It is clear to me you have to have a myeloma specialist on your team if you are going to get your best possible outcomes. It doesn't mean you have to go there for every infusion that you get or even every blood lab test that you get. But as you can see, the depth of experience with these individuals treating myeloma uniquely is extraordinary. So if you do not have a myeloma specialist on your team, please include one, especially when you are making a treatment decision. It's just critical. So thank you again. Let's give them another round of applause. It's amazing that they're here.